Parkinson's disease. Introduction. Parkinson's disease, PD, is a progressive neurodegenerative disorder that primarily affects movement. It is characterized by motor symptoms such as tremors, rigidity, bradykinesia, slowness of movement, and postural instability. Parkinson's disease is caused by the degeneration of dopamine-producing neurons in the substantia nigra, leading to a deficiency of dopamine in the brain. This condition affects millions of people worldwide and significantly impacts their quality of life. Definition. World Health Organization, WHO. Parkinson's disease is a chronic, progressive neurodegenerative disorder that primarily affects motor function due to the loss of dopamine-producing neurons in the brain. National Institute of Neurological Disorders and Stroke, NINDS, a disorder that results from the progressive loss of dopamine-producing brain cells, leading to tremors, rigidity, and difficulty with movement and coordination. Etiology. Genetic factors, mutations in genes such as LRRK2, PARK7, PINK1, and SNCA are associated with Parkinson's disease. Environmental factors, exposure to pesticides, herbicides, heavy metals, and toxins may increase the risk. Oxidative stress, free radicals damage neurons, contributing to neurodegeneration. Mitochondrial dysfunction, impaired energy production in brain cells may lead to cell death. Aging, the risk of Parkinson's disease increases with age, particularly after 60 years. Risk factors. Age, the risk increases significantly after the age of 60. Genetics, family history and genetic mutations, LRRK2, SNCA, PARK7, PINK1, may increase susceptibility. Gender, men are more likely to develop Parkinson's than women. Environmental exposure, pesticides, herbicides, heavy metals, and air pollution have been linked to higher risk. Head trauma, a history of traumatic brain injury may contribute to the development of Parkinson's. Oxidative stress and mitochondrial dysfunction, damage to brain cells from oxidative stress can lead to neurodegeneration. Pathophysiology. Degeneration of dopaminergic neurons. Loss of neurons in the substantia nigra. Down arrow. Dopamine deficiency. Reduced dopamine levels in the basal ganglia. Down arrow. Imbalance of neurotransmitters. Excess acetylcholine relative to dopamine. Down arrow. Motor dysfunction. Tremors, rigidity, bradykinesia, postural instability. Down arrow. Non-motor symptoms. Cognitive impairment, depression, autonomic dysfunction. Down arrow. Progressive disability. Loss of independence in daily activities. Clinical manifestations. Motor symptoms. Tremors, resting tremors, involuntary rhythmic shaking, usually starting in the hands or fingers when at rest. The tremor typically decreases with voluntary movement but worsens during periods of stress. Muscle rigidity, stiffness and increased muscle tone that can cause discomfort and limit the range of motion in the arms, legs, and trunk. This rigidity can lead to muscle pain and cramps. Bradykinesia, slowness of movement, a hallmark symptom where movements become slow and difficult to initiate. Patients may struggle with tasks like buttoning clothes or rising from a chair. Postural instability, loss of balance and coordination, increasing the risk of falls. Patients may have difficulty maintaining an upright posture, and some develop a forward-leaning stance while walking, stooped posture. Non-motor symptoms. Depression and anxiety, mood disturbances are common in Parkinson's patients due to changes in brain chemistry and neurotransmitter imbalances. Depression can affect motivation and quality of life. Cognitive decline, mild cognitive impairment can occur early, progressing to dementia in later stages. Patients may struggle with memory, problem solving, and decision making. Sleep disturbances, many patients experience insomnia, excessive daytime sleepiness, restless leg syndrome, or REM sleep behavior disorder, leading to poor sleep quality. Autonomic dysfunction. Dysfunction of the autonomic nervous system can cause symptoms like constipation, urinary incontinence, excessive sweating, and low blood pressure, orthostatic hypotension, leading to dizziness upon standing. Other symptoms. Masked facial expression, also known as hypomimia. This is a reduction in facial expressions due to muscle rigidity, making it difficult for patients to convey emotions. Micrographia, a progressive shrinking of handwriting, making it difficult for patients to write legibly as the disease progresses. Difficulty swallowing. Dysphagia, impaired coordination of the muscles used for swallowing, increases the risk of choking and aspiration pneumonia, a serious complication. Diagnostic evaluation. Medical history and neurological examination. A thorough review of symptoms, medical history, and family history is conducted to assess disease progression and rule out other neurological conditions. The neurologist evaluates motor functions such as tremors, rigidity, and bradykinesia through physical examination. Unified Parkinson's Disease Rating Scale, UPDRS. This standardized tool measures the severity and progression of Parkinson's disease by assessing motor symptoms, daily activities, and overall mental and emotional well-being. It helps track disease advancement over time and guide treatment decisions. Dopamine transporter, DAT, scan. This specialized imaging test detects dopamine deficiency in the brain by evaluating the function of dopamine transporters. It is particularly useful in distinguishing Parkinson's disease from other movement disorders with similar symptoms. MRI and CT scans, magnetic resonance imaging, MRI, and computed tomography, CT, scans are used to rule out other neurological conditions, such as strokes, brain tumors, or structural abnormalities. While they do not confirm Parkinson's disease, they help exclude other possible causes of symptoms. Levodopa challenge test. This test evaluates the patient's response to levodopa, a dopamine precursor used in Parkinson's treatment. A significant improvement in symptoms after taking the medication supports the diagnosis of Parkinson's disease, distinguishing it from other movement disorders. Medical management. Dopaminergic medications. Levodopa-carbidopa is the gold standard treatment for Parkinson's disease, helping to replenish dopamine levels and improve motor function. However, long-term use may lead to motor complications like dyskinesia. Dopamine agonists. Pramipexole and ropinirole stimulate dopamine receptors directly, mimicking dopamine action. These drugs are useful in early-stage Parkinson's or as an add-on therapy but may cause side effects like hallucinations. MAO-B inhibitors. Selegiline and rasagiline slow dopamine breakdown by inhibiting monoamine oxidase B enzymes. These medications help prolong dopamine effects, providing mild symptom relief, especially in early disease stages. COMT inhibitors. Entacapone extends the effects of levodopa by preventing its breakdown outside the brain. This helps reduce motor fluctuations and provides more consistent symptom control. Anticholinergics. Trihexyphenidyl is used primarily for tremor control by blocking excess acetylcholine activity. It is often prescribed to younger patients but may cause cognitive side effects in older individuals. Surgical management. Deep brain stimulation, DBS. This procedure involves the surgical implantation of electrodes into specific regions of the brain, such as the subthalamic nucleus or globus pallidus. These electrodes are connected to a neurostimulator, similar to a pacemaker, which sends electrical impulses to regulate abnormal brain activity. DBS helps improve motor symptoms like tremors, rigidity, and bradykinesia. It is typically recommended for patients who no longer respond well to medication but do not have severe cognitive impairment. Pallidotomy and thalamotomy. These are less commonly performed procedures that involve surgically destroying a small part of the brain responsible for abnormal movements. Pallidotomy involves lesioning a portion of the globus pallidus to reduce muscle rigidity and improve movement. Thalamotomy targets the thalamus, specifically for treating severe tremors that do not respond to medication. Rehabilitation and supportive care. Physical therapy. focuses on improving movement, flexibility, balance, and strength. Regular physical therapy sessions help patients reduce muscle rigidity, improve coordination, and prevent falls. Therapists may introduce exercises like walking, stretching, and resistance training to maintain mobility. Occupational therapy helps individuals adapt to daily activities to maintain independence. This includes strategies for dressing, bathing, and eating, as well as modifications to the home environment, such as using adaptive utensils or installing grab bars for safety. Occupational therapists also provide techniques to manage tremors and enhance fine motor skills. Speech therapy addresses difficulties with speech and swallowing, which are common in later stages of Parkinson's. Speech therapists use exercises to strengthen vocal cords, improve articulation, and enhance voice projection. They also work on techniques to prevent choking and ensure safe swallowing by modifying food textures and encouraging proper head positioning during meals. Nursing management. Nursing diagnosis, impaired physical mobility related to muscle rigidity and bradykinesia. Interventions. Encourage daily exercise to maintain muscle strength. Assist with mobility aids to prevent falls. Educate on movement techniques to enhance mobility. Nursing diagnosis, risk for aspiration related to dysphagia. Interventions. Monitor swallowing ability and provide soft textured foods. Encourage slow and deliberate chewing. Position patient upright during meals. Nursing diagnosis, impaired verbal communication related to facial muscle rigidity. Interventions. Encourage speech therapy exercises. Use communication aids, writing boards, electronic devices. Provide a calm and supportive environment. Prevention. Regular physical exercise to promote brain health. Healthy diet rich in antioxidants and omega-3 fatty acids. Avoiding exposure to environmental toxins. Engaging in mentally stimulating activities. Complications. Progressive loss of motor function leading to disability. Cognitive decline and dementia. Increased risk of infections due to immobility. Depression and social isolation. Conclusion. Parkinson's disease is a chronic and progressive neurodegenerative disorder with significant impact on motor and cognitive functions. While there is no cure, early diagnosis and appropriate management with medications, physical therapy, and surgical interventions can help improve quality of life. A multidisciplinary approach involving neurologists, physical therapists, speech therapists, and nursing care is essential for effective disease management.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.